and the patient was diagnosed as myasthenia gravis with thymoma, and the patient was kept on injection pyridostigmine 60 mg TID and prednisolone 20 mg OD since 1 month, and case was posted for open-wide mediastinal thymoma excision. Pre-M3 patient was evaluated and the vitals are normal, and pre-M3 preparation patient was kept on albendazole 0.25 mg before surgery, and the morning dose of injection pyridostigmine 60 mg and prednisolone 20 mg was taken, and all the monitors were kept ready, and the patient was anesthetized and pre-medicated with injection glycopyrrolate 0.2 mg IV and metoclopramide 20 mg IV and fentanyl 150 micrograms, and induced with injection propofol 100 mg IV and sevoflurane, and intubated with injection atracurium 6 times muscle relaxation non-depolarizing, and maintained with sevoflurane and oxygen air ratio, and atracurium 1 mg intermittently was given based on the train of food response, and dexmedetomidine infusion was kept as adjuvant. Post-operatively, patient was not extubated and kept on ventilator, and gradually weaned off from the ventilator after 3 hours when the patient was fully conscious and adequate tidal volume was attained. Coming to discussion, myasthenia gravis is a antibody autoimmune-mediated disorder, and there will be decrease in the number of postsynaptic acetylcholine receptor at neuromuscular junction due to autoimmune destruction of the receptor. Clinical features: patient presents with weakness, fatigability, and diplopia. In the severity, there will be respiratory failure also developed, and neurological symptoms are generally absent. Coming to investigations, anti-acetylcholine receptor antibody assay is the most specific one which we can rely upon, and the single fiber electromyography, enterophonium test, and CT-MRI is used for diagnosing any thymoma delineation. Coming to anesthetic considerations, preoperatively patient will be taken based on the severity and respiratory muscle strength. We have to do pulmonary function test to assess the lung adequacy, and anticholinesterase on the morning of surgery should be given. If the patient is having severe respiratory weakness, we have to do plasmapheresis also. Anesthetic drug interactions, intravenous anesthetic generally propofol is the best drug used. Opioids can also be used, but it is better to go for short-acting opioids like lamivudine. Inhalation anesthetic, sevoflurane was suitable. Isoflurane generally avoid because it causes neuromuscular junction blockade. Muscle relaxant, generally depolarizing muscle relaxants are avoided. They have to be given in higher doses. The 80-95 of acetylcholine is 2.6 times that in non-myasthenic patient. There will be chances of prolonged blockade, even phase 2 blockade may also occur. Non-depolarizing neuromuscular blockade, the myasthenic patients are more sensitive to non-depolarizing muscle relaxant. We cannot predict how it will act generally. So, non-depolarizing muscle relaxant, there will be long-acting, long duration of action may be present. This is a graphic representation of the dosage where atracurium vicurium, generally less amount of doses is used in myasthenic patient compared to normal patients. Interaction with other drugs also present at the neuromuscular junction. There are several other drugs which interact at neuromuscular junction, like aminoglycosides, polymyxins, beta-adrenergic blockers, steroids, and procainamide. So we have to taken care of preoperatively whether any patient is using any of these drugs or not. Coming to regional anesthesia, local anesthetic decreases the sensitivity of post-junctional membrane to acetylcholine. Even external anesthetics like cocaine, procaine, they have which are metabolized by cold anesthetics, there will be diminished metabolism of those drugs. So reduced dosage of amides is used. Thoracic epidural is the best for post-op anesthesia in such cases. Post-operative consideration based on the preoperative condition of the patient's surgical procedure, residual anesthetic effect, we have to assess the patient. There is a predictive criteria which includes duration more than 6 years, history of COPD, pyridostigmine, and vital capacity. We have to assess the post-operative ventilator support required or not. We have to consider among this also myasthenic and cholinergic crisis. Generally, post-operatively, patient is better not to extubate. We should not give reversal agent, because when we give reversal agent, the acetylcholinesterase receptor inhibitor, there will be interacting with the cholinergic receptors. We cannot clearly demarcate between myasthenic and cholinergic crisis. So that we have to better to keep the patient on acetylcholine ventilator. We have to keep the patient on ventilator support and gradually wean off based on the respiratory adequacy whether it attained or not. Conclusion: myasthenia gravis is a disease of greater significance to anesthesiologists because it affects the neuromuscular junction. Potency for respiratory compromise in these patients require the anesthesiology to be familiar with the underlying disease state.
Thank you very much.
Thank you.
I muscle relaxant, it could have been, I mean, in which way? I have no experience clinically. I want to know the benefits of giving general anesthesia. If you could do it with epidural bupivacaine plus remifentanil and then propofol itself, completely avoiding the muscle relaxants so that the problem of myasthenia gravis would be managed easily. It's my theoretical question.
If we open a patient while he is awake, his sternum, it will be much more stressful to the patient. So better regional anesthesia. We can go for a regional anesthesia also, madam, for epidural. But it is better go for a general anesthesia in such cases because it is much more stressful to the patient.
It is the surgeon's choice.
No, you used an analgesic which is not tried and tested in myasthenia. How do you support that? The new analgesic which is long acting.
Here we have relied upon the thoracic epidural anesthesia. That means we have given local anesthetic for epidural space so that analgesic will be adequate. It will not interact with neuromuscular junction.
Thank you very much. Mucopolysaccharide disease, a focus on neuropsychiatric and behavioral aspects.
A very good morning. The title of my presentation is Hunter Syndrome, a focus on neuropsychiatric and behavioral aspects. I will be dealing this topic on the following subheads: introduction, clinical description, discussion, and conclusion. Coming to introduction, we reported two very rare cases of Hunter syndrome came for mental retardation certification to psychiatric OPD. And you know that it's very rare. The incidence is 1 in 1,70,000 births. And especially in India, the focus on neuropsychiatric and behavioral aspects has not been laid on previously. So we know Hunter syndrome is a type 2 mucopolysaccharides. This is a deficiency of enzyme iduronate to sulfatase. It results in accumulation of GAGs, that is glycosamine glycons, in various cells, body, and connective tissues, which results in permanent and progressive cellular damage. Coming to clinical description, we reported two South Indian brothers, one is of 11 years and another one is of 8 years, the history of delay and regression of developmental milestones. And both of them presented with hyperactivity, impulsivity, aggressive behavior, distractibility, and sleep disturbance. The younger one is a deaf mute since birth with a history of a progressive increase in shortness of breath, and there is excessive snoring and disturbed sleep. This diagram is showing the extended rescue pattern. We can see the two affected children here, and there are 3 affected children in the maternal side. All are male children who died at the age of 15 years. And these pictures show the clinical features, that is macrocephaly, we can see the facial dysmorphism, there are joint contractures. These are the trigger fingers because of accumulation of glycosamine glycons in the fingers, and we can see dorsal kyphosis in the neural. This picture shows a macroglossia and also decidual teeth are not shed, and there's thickened lips. There's classical features. From systemic examination, CNS examination, there is a kyphosis in the neural, there's hypertonia, exaggerated uterine reflexes, and there's violated plantar flexion. And fundus is normal, with a normal visual function in both, and there is mixed hearing loss on PTA. So in the GNP, the distinct abdominal hepatosplenomegaly with a positive common impulse, and the respiratory system, there are diffuse bronchi, and the systolic murmur is serious. So suspecting an NPS based on the clinical profile, we did a series of radiological investigations. So here we can see a microcephaly, a thickened cortical bone, the posterior flattening of ribs, underdeveloped carpal bones, and there is a classical J-shaped cellular calcica. And this is a non-massive CT of the 11-year-old, which is hydrocephalus. There are enlarged CSF spaces. 2D echo shows MR, it's matrix station. There is hepatosplenomegaly and ultrasound abdomen, and there is umbilical hernia. So we did a screening test, the Wood-Nodin blue test, which recognized the GAGs. There is a purple spot against the blue background and bottom of the paper. And we did DS, the developmental screening test for the IQ assessment, which reported 21 and 23 in the Indian and 11-year-old respectively. And we did, for social cohesion, we did Vineland social maturity scale, which gives 1, which indicates a 90% of disability. We also performed a rating scale CHAPAS given by Lee and Fernlander, which basically recognizes psychiatric comorbidity in mental retarded children. So we observed ADHD in the younger sibling, but not in the elder sibling. Coming to discussion, this PSF was described by Charles Hunter. It's heterogeneous disorder, maybe there is a onset as well as severity. The severe form, the initial signs and symptoms are seen in between 1.5 years to 4 years, whereas the intermediate phenotypic form, we see the abnormalities after 2 years, so which may have normal intelligence and is avoidable to adulthood also. And we know, I'll explain, the trigger is a result of gag deposits and the communicating characteristics which we have seen result in many neurological signs. So the severe hearing loss, disturbed sleep and cognitive impairments may contribute to behavioral abnormalities, which we have seen in both children, like inattentiveness, impulsivity, we see in the elder sibling in this case, and easy distractibility. So we have seen these disorders, behavioral disturbances, mostly in the younger child, but not in the elder one. This can be explained based on the phenomenon of neurodegeneration. That is, as the child grows, the neurodegeneration, the behavioral abnormalities come down. Or it can be explained based on the phenomenon of diagnostic overshadowing. That is, it's tough to diagnose psychiatric illness in severe MR. So then the question of diagnostic overshadowing comes. So ADHD incidence can be explained based on biological theory, that is a brain which results in the mental retardation, also predisposes to individual to a mental disorder. So next, coming to the management, the specific management is recombinant human enzyme, which is the infusion, a weekly interval infusion, and bone marrow transplantation is specific management. So, but no emphasis has been made on psychiatric and behavioral abnormalities and their management. So we offer psychotherapy and supportive psychotherapy with the target goals of improving basic coping skills, social functioning, and activities of daily living. And there is special reference to the parental counseling and supporting therapy education. And for the ADHD management, we use methylphenidate, etomoxetine, risperidone. And the progress is poor. And we haven't done the confirmatory tests. And coming to conclusion, there is a myth that mental retarded child labeling the person as inappropriate candidate for psychotherapy, but it's not true. We can improve the quality of that definitely if we properly diagnose earlier and give a proper support to management. These are my references. Thank you.
4th International Congress of 2014. Few claps, please. Thank you.
Good morning, everybody. So, I want to present a few interesting cases what we have received in our department. This paper was presented about 2 years back in our IIM conference. And you know, most of the ethnic tumors they arise from the sweat glands. A few from the hair follicles. And usually, these may be diagnosed by the dermatologist or after diagnosis they may refer to the surgeons. And nowadays, plastic surgeons are also interested because they want less scar the patients. So plastic surgeons are also sending these tumors to our department. So to start with, case 1 and 2, these are females around 38 years. They are presented with small tumors of 8 months duration and 6 months duration respectively. So these are, skin covered masses of about 2.5 to 3 centimeters. And cut section shows a raised nodule in the dermis extending into the subcutaneous tissue. These are solid and cystic. So here you can see the surface squamous epithelium, and there is a small ulceration below that there is a lobulated tumor. And here you can see the duct-like structures with secretions. Some of the cells are activated. And here also you can see solid portions of the cells which are polyhedral in shape, and some of the cells are clear. So we call this as clear cell hydradenomas. There are large cystic spaces, you can observe this here. So nodular hydradenomas occur in acroscleromas. So this arises from the ducts of the sweat glands, and usually there is associated ulceration of the skin. So you can do special steps like direct EAB. Usually we don't have any doubt in diagnosing these things because they have a specific structure. Then third case, 45 years male presented with recurrent swelling on the left side of the forehead since 7 months. It's a solitary skin covered lesion measuring 3 to 2 centimeters. There is grittiness, solid cystic areas gravid with a focus on hemorrhage, probably because of the previous fine needle aspirations. And here you can see, if you give any pathologists, they will say it's a mixed thyroid tumor or pleomorphic adenoma. So this is a very rare tumor occurring in the skin. I have seen very few cases. One in the leg region, the other in the forearm region. So you can appreciate the ductile structures. So we call it as chondroid serigoma or mixed tumor of the skin. It just resembles like a pleomorphic adenoma. There is no doubt about it. And sometimes we can do PIS stain and also action stain. There will be mutant stomach stains with action. Then case 4, presented the swelling of the scalp with ulceration. FNAC showed cellular smears with epithelial cells arranged in sheets and clusters. There are 2 types of cells, polygonal cells, with geometric cytoplasm at basic and see this. Here you can see there is a, typically we can say it's a keratinous material and squamous cells. And here is the gross picture, an ulcerated lesion skin. And here you can see the epidermis with the underlying cells. And there are a number of keratinous areas, abrupt keratinization is found here. Here also you can see there is calcification, the arrow shows